Today, we're going to be talking about our approach to the critically ill child. My name is Iman Lubani, and I'm a pediatric emergency physician at London Health Sciences Centre in London, Ontario, Canada. I have no financial or commercial interests to disclose. Our objectives for this talk today are to describe the members of the resuscitation team and discuss how we assign team members roles during a resuscitation, to develop an approach to estimating a child's weight, to learn how to prepare the equipment and medications that we may need prior to our resuscitation, to review the importance of developing a differential diagnosis for the critically ill child, to develop an approach to the primary survey in a critically ill child, and to develop an approach to the secondary survey in a critically ill child. So to start off with, we'll take a look at the resuscitation team and its makeup. The number of resuscitation team members varies depending on the site you may work at, the size of your center, or even the time of day. Many hospitals have smaller teams on overnight as compared to the daytime, for example. Assigned team roles can also vary, but most teams include a resuscitation or trauma team leader, an airway manager, and depending on your center, this may be a respiratory therapist, a medication provider whose role it is to prepare and administer medications, an IV or IO access initiator, a recorder whose job it is to record the events of the resuscitation and keep track of time during a resuscitation, a CPR provider who would be in charge of delivering chest compressions when needed, and a defibrillator operator who would be in charge of operating the defibrillator when it's needed. When should we assign roles to team members? Ideally, this should occur prior to the arrival of the patient, but this is only possible if you have an advance notice of the patient's arrival. When the patient arrives suddenly or a patient already in the department deteriorates, becoming critically ill, the team should take the time to assign roles to prevent confusion during the resuscitation and allow for the smoother functioning of the team. An attempt should be made to match roles to each team member's expertise. For example, if a respiratory therapist is present, assigning them the airway, the most experienced physician should be assigned as resuscitation or trauma team lead, etc. Each team member should be clear on their priority, which is their assigned role, but team members can offer help to their fellow team members whenever necessary. Estimating patient weight is particularly important in the pediatric population. Most medications and equipment sizes are based on a patient's weight, and it's often not possible to weigh the critically ill child while resuscitation is ongoing. There are different methods of estimating weight in a child, but the most accurate method has been shown to be parental weight estimation. I'll often ask parents, when was the last time you weighed your child and what was their weight then? If parents are unavailable or unable to estimate the child's weight, the Broslow tape can be used. The Broslow tape uses the patient's length to estimate weight and also provides the doses of commonly used resuscitation drugs based on that estimated weight. There are now also pediatric resuscitation phone apps that allow you to estimate weight based on a child's age, such as Pedistat or PediQuickCalc, but these are based on average weights for age, so may not be accurate for children who, for whatever reason, are far above or far below the average weights for age. If we have time prior to a patient's arrival, we should consider what equipment may be needed for the resuscitation and prepare that equipment. Equipment that should be on hand to manage the airway would include an oxygen source, as well as a method of delivery, such as nasal prongs or a face mask. Suction should be available to clear secretions from the airway. An oral airway should be ready in case of need. A bag valve mask ventilator with an appropriately sized mask for bagging in case the patient requires it. ET tubes with half a size larger and half a size smaller available in case of need. A laryngoscope with an appropriately sized blade, and video-assisted laryngoscopes such as a glide scope, depending on provider comfort. IV equipment as well as IO equipment should be readied. An appropriately sized NG tube for age should be available. A defibrillator should be on standby in case of need, and a footstool, which often comes in handy when chest compressions are required. This list is far from exhaustive, but the idea is to make sure you have an approach to preparing equipment so that you're not fumbling around for things during a resuscitation and losing valuable time. Next, we need to consider what medications should be prepared for resuscitation. Medications for rapid sequence intubation include fentanyl for analgesia, ketamine for induction, and rocuronium for paralysis. At our center, we use a 3-2-1 rule for these medications, so fentanyl at 3 micrograms per kilogram, ketamine at 2 milligrams per kilogram, and rocuronium at 1 milligram per kilogram. Cardiac meds should be available in case of need, and the most commonly used of these medications is epinephrine, which is used in its 1 in 10,000 IV formulation at a dose of 0.01 milligrams per kilogram or 0.1 milliliters per kilogram. Adenosine is another cardiac med that's used in the treatment of SVT or supraventricular tachycardia. Seizure medications should be prepared when there's a history compatible with seizure. Benzodiazepines are our first-line seizure medication, with lorazepam being the most commonly used benzo at our institution. Second-line medications include phenytoin, levetiracetam, also known as Keppra, and phenobarbital. Historically, phenytoin was our go-to second-line medication, but over the past few years, it's been replaced by levetiracetam. Phenobarbital is not a favorite due to its side effects, including hypotension, cardiac arrhythmias, and hypopnea, but it seems to be making a comeback. And in cases where infection is suspected, the most commonly used antimicrobial in resuscitation is ceftriaxone, because it's a broad-spectrum IV antibiotic that can be delivered IV push with relatively few side effects. An often neglected part of the preparation process in resuscitation is the development of a differential diagnosis for the patient presentation. But I am here to drill it into you that this is an important part of your resuscitation. If you don't keep your mind open and consider a broad differential, you'll be unable to effectively treat the underlying problem that is causing your patient's clinical deterioration, and you'll miss important treatment options. Remember to keep your differential diagnosis broad. A trick I used going through residency was to make sure I came up with at least 3 possible causes for my patient's presentation. Once you've started thinking, you typically will come up with far more than 3, but it's a way to stimulate your deeper thinking process. Make sure to revisit your differential during the resuscitation process as new information or new clinical findings become apparent. The ABCDDE mnemonic provides a structured approach to the primary survey in a critically ill child. In this approach, we use ACT to remind us that we are A, assessing the patient, C, communicating with team members, and T, treating issues as they're identified. You can think of it as a see something, say something, do something approach. And remember to reassess regularly to determine the effects of the treatments you've initiated. In ABCDDE, A stands for airway, and we add C-spine to remind us to consider the need for C-spine immobilization, B for breathing, C for circulation, DD for disability dextrose, and E for exposure. This is followed by ancillary testing, such as labs, imaging, including chest x-ray, pelvis x-ray to rule out pelvic fracture in trauma patients, x-rays of deformed or swollen extremities to assess for fracture, FAST exam, which is a bedside ultrasound exam of the heart, looking for pericardial effusion, the lungs, looking for pneumo or hemothorax, and the abdomen, looking for free fluid that may be due to intra-abdominal injury. ECGs can also be done if there's a concern about cardiac arrhythmia or ischemia. We're now going to take a closer look at each of the components of the ABCDDE exam. In assessing the A, airway, we're assessing for airway patency. Is there vomitus or blood obstructing the airway? Are there any foreign bodies in the airway? We're thinking about whether or not the C-spine requires immobilization, such as in the case of known or suspected traumatic injury. We're assessing the trachea to see if it's midline. If there's a deviation of the trachea, we're considering a tension pneumothorax. We communicate our findings to our team members, and I like to do this in a loud, clear voice. Often the resuscitation room is abuzz with many voices, and it's difficult to hear in there, so one must communicate in a clear manner. We treat any issues that may be noticed, so if the airway is obstructed, we'll suction the airway or sweep out debris. We'll put the patient in the sniffing position and apply a chin lift or jaw thrust to ensure airway patency, and we'll apply a C-collar if indicated. For breathing, we start with the relevant vitals, in this case the patient's oxygen saturation and the respiratory rate. We observe for symmetry of chest rise and for obvious bruising or trauma to the chest. We auscultate the chest to assess for breath sounds. Are there breath sounds bilaterally? Are they equal or decreased? Are there any adventitious sounds such as crackles or wheezes? We again communicate these findings with our team and then treat by applying oxygen for decreased oxygen saturations, bagging for apnea or hypopnea. We consider inserting a chest tube for pneumothorax or hemothorax. For wheezing, we consider bronchodilators, and for stridor, we may consider nebulized racemic epi and IM or oral dexamethasone. And again, after each of these interventions, we're reassessing the patient to ensure that the intervention has had the desired effect. For circulation, we note the relevant vital signs again, in this case, the heart rate and blood pressure. We look for any signs of major bleeding, which can occur in the chest cavity, in the abdominal cavity, in the pelvis, or through open fractures of the long bones. These are areas where enough blood can be lost to impact the patient's hemodynamic status. We palpate central pulses. In children, we most often use femoral pulses as they're most readily accessible, but in older children and adults, you can use the carotid pulses as well. We then palpate peripheral pulses, and most often we use the radial pulses and dorsalis pedis pulses, and we measure capillary refill centrally, usually on the chest. We communicate our findings to our team and then treat by giving a bolus of isotonic fluids for tachycardia or hypotension that's due to hypovolemia. We consider blood products in cases where there's hemorrhage, and we stop active bleeding by applying a tourniquet or pressure dressing when possible. And again, we reassess the effects of each intervention to ensure that it's had the desired effect. For disability dextrose, we assess the relevant vitals, and in this case, our point of care glucose is an important vital sign. That's the dextrose portion of the DD. We assess pupillary size and reactivity. We assess limb movement in all four limbs. We use either the AVPU or GCS scales to assess the extent of the patient's impaired consciousness. We communicate our findings with our team, and in the presence of hypoglycemia, we treat with IV glucose. In these cases, I like to use the rule of 50 to remind me of the dosing of the glucose. Everything we're using has to multiply to give you 50. So for example, if I'm using D50, I give 1 milliliter per kilogram. 50 times 1 is 50. If I'm using D25, I give 2 milliliters per kilogram. 2 times 25 is 50. If I'm using D10, I'm giving 5 milliliters per kilogram, and if I'm using D5, I'm giving 10 milliliters per kilogram. In children, D50 and D25 are not given through peripheral IVs because they can cause phlebitis and thrombosis at the site of injection. So when using a peripheral IV, we give either D10 or D5. In patients with findings consistent with increased intracranial pressure, such as Cushing's triad, so hypertension, bradycardia, and irregular respirations, or bulging fontanelle in infants who have open fontanelles, or unequal pupillary size, we treat with either IV hypertonic saline at a dose of 3 milliliters per kilogram or IV mannitol at a dose of 1 gram per kilogram. And again, I'm going to keep saying this. After we're done, we reassess how our interventions have affected the patient. I wanted to take a moment to review the pros and cons of using the AVPU scale versus the Glasgow Coma Scale or GCS. AVPU stands for A, alert, V, verbal, so responds to verbal stimuli, P, pain, responds to painful stimuli, and U, unresponsive. P correlates with a GCS of approximately 8. I'd argue that in the setting of resuscitation, the AVPU scale serves the purpose of sufficiently describing the patient's state in a way that's easy to remember, uncomplicated, and easy to communicate. In a study by Janagama et al., published July 2022 in the American Journal of Emergency Medicine, the authors reviewed pre-hospital data using both AVPU and GCS scores and showed that the AVPU score was a good predictor of mortality at 48 hours. That being said, our institution still uses the Glasgow Coma Scale, which adds a little more information on patient level of consciousness. We chart the GCS with a breakdown of the eye-opening, verbal, and motor responses to make it easier for us to keep track of changes in the patient's level of consciousness. Moving on to exposure, we want to expose the patient so that we can visualize the entire body, making sure to maintain patient dignity whenever possible. The vital sign here is temperature, which we measure either rectally or in the axilla, with rectal temperatures being the most accurate form of measurement. We're looking for any obvious bruising, swelling, deformity, or tenderness. We log roll the patient to examine the back for the same, and we check rectal tone by asking the patient to bear down as though they're trying hard not to poop, and we look for the anal wink. We generally don't do digital rectal exams in children because they've been shown not to add any information to the exam, and they can be quite painful and traumatic for a child. We communicate our findings to the team and then treat hypothermia using a warmer, blankets, or a bear hugger. We treat hyperthermia or fever with antipyretics because hyperthermia can increase metabolic demand as well as make our patients uncomfortable. We splint any obvious deformity, and we stop any active bleeds with a tourniquet or pressure dressing. And as always, we are reassessing each of our interventions to make sure that they've had the desired effects. Once the primary survey has been completed, we can then move on to the secondary survey, which is a more detailed exam of the patient from head to toe to uncover any injuries that may have been missed during the primary survey. I move down the patient's body, starting at the scalp, looking for any obvious hematomas or bleeds, and move from there to the ears using an otoscope to examine for obvious trauma or hemotympanum. I palpate the orbits in the face, looking for any obvious deformities, indicating facial or orbital fractures. I examine the eyes, looking for any obvious ocular trauma. I examine the mouth and dentition, looking for any intraoral injuries or dental fractures. I move down the neck to the clavicles and then down each arm, palpating along the entire length of the arm and hand as I go, looking for any tenderness, swelling, or deformity. I re-examine the chest, abdomen, and pelvis. I examine the genitalia, looking for any blood at the urethral meatus that may indicate a urethral injury. And then I move on to the legs, once again, palpating down each leg all the way to the toes. Doing this ensures that no important injuries are missed. Once we've completed our secondary survey, we go back and repeat our primary survey until the patient is stabilized or transferred. As we're doing this, we're also assessing the effects of our treatments or interventions on the patient's clinical status, ensuring that we capture any changes in the patient's clinical status as we go. So today we've hopefully learned how to organize a resuscitation team and assign roles to each team member, how to prep and what to prep in advance of resuscitation, how to use the ABCDDE approach to perform a primary survey, how to perform our secondary survey, and most importantly, God willing, how to keep our patient alive. So that's it for us. If you have any questions, don't hesitate to send me an email, and I can't wait to see you all in the Pediatric Emergency Department. Best of luck to you all.